Thank you so much, everyone, for having me. I really wish that we could be in person. I love to speak and I love to be able to see my audience. So Zoom is always a little bit more difficult, but we will go from there. I'm going to spend about 25 minutes just giving you an overview of where I think we are, some considerations, some health behaviors that may be beneficial, and then we'll take the rest of the time to really get into some discussion and to hopefully answer some of your questions and keep everyone's anxiety levels down. It's a very difficult time. I said it reminds me of a title song for the Beatles, "The Long and Winding Road," right? When are we ever going to get out of this? So next slide, please. Oh. Okay, so just to give you a few, what I want to spend a very few short minutes on is public health, how public health has already been responding here in Orange County, and what some of the data that we've collected, how that fits into the Delta variant and Delta response. And so just so you know, we've been a program in public health for a while. I started at UCI about 2 years ago, and my goal is really to transition to take what is a very powerful program in public health. We have about 1,600 students at any one time and a very substantial faculty. I know you've heard a lot of them talk about COVID, people that you probably have heard in the news, Andrew Neumer and Daniel Parker, for example, are part of our program in public health. We are focused on evidence-based science. We have state-of-the-art research, and the kind of areas that we're really experts in include infectious and chronic disease, the social determinants of health, environmental health, clean air, clean water, and then what we call health society and behavior, as well as global health. All of our work, it's not just about thinking things through and putting them on paper, but we believe in public health that we have to, that action is the only way we get to health equity. And we're transitioning to another school. Next slide, please. So I wanted to just talk about some of UCI's public health roles during COVID. As I was already introduced, we've had a leadership role. We've been involved in the vaccine task force, in the pediatric vaccine task force, in really making sure that all of the communities around Orange County have equal access to information, to vaccines, and really advocating for relationships with community so that we are in partnership with community and really trying to address and meet the needs of community, all communities, Santa Ana, Irvine, San Clemente, all of the communities north to south in Orange County, and then of course working with the state as well. Next slide, please. Next slide. Okay, let's see. Could we go to great. Okay, keep going. Next slide. So I just wanted to talk about a couple of different things that are relevant to Delta. And so I would say we've been involved in a couple of very important programs that have impacted all of you. One is that we designed a health equity contact tracing training last summer, training over 700 people in Orange County to conduct contact tracing with a health equity lens focus. And we're still at UCI. We trained community health workers, we trained folks at the county level, and we are still doing major contact tracing as a university. That all stemmed out of that contact tracing workshop. And you can go to the next slide. Last summer, we did a seroprevalence study of the entire county. Remember when we didn't know what the exposure to initial COVID was? Well, we did this whole study across the entire county of Orange, and we found a prevalence of about 12% at that time. Clearly, it's higher now, but that Latinx populations were significantly more likely to bear the burden of COVID than other populations, as were low-income households. And again, I think we all know that it's a disease of disparities hitting Latinx populations and also older populations. Next slide, please. More recently in December, Santa Ana asked us if we could come in and do a random sample of their population to really understand the burden of COVID among Santa Ana residents. And again, this is now December, that you were at a twofold greater likelihood, again, a disease of disparities, if you were a Latinx than if you were not, that you were at 75 times greater likelihood of having been exposed to COVID and having antibodies if you worked outside the home, if you were an essential worker. A lot of those essential workers were working in the food, grocery, restaurant industry, that for each person in the household, there was an additional 9% risk of COVID. So larger households had significantly larger risk of COVID. And we also found in December that 30% of the population of Santa Ana had antibodies towards COVID, that there was no difference in that antibody prevalence of 30% between children and adults. And this is one of the first studies to demonstrate that children got COVID just as adults got COVID, maybe with less symptoms. Next slide, please. So where are we now? And so we are in a very interesting place scientifically, but a scary place, I think, for all of us. I'm not scared. You shouldn't be scared. You should just understand what's going on. There's a lot of discussion about waning immunity. So people that got their their immunizations, their vaccines, and vaccine really is the only way to handle COVID. People who were vaccinated in early in December when the vaccine first came out, in January and February, it looks like the efficacy of the vaccine is waning a bit. At the same time, in Orange County, as we know, all masks were off on June 15th. We are in the middle of back to school. And of course, we have this Delta variant. Next slide, please. So what do we face? We're facing this great unknown, responding to fear, anxiety, uncertainty, and denial. And the interesting thing is that this slide was initially made a year ago. And in a way, we're still facing that. We're going through these surges, ups and downs. We know that there's still stigma, that there's this whole component of vaccine is unsafe, I'm not at risk. There's a lot of polarization of what is a public health neutral discourse has now become politicized. And we are really in pandemic fatigue, as I was talking to Jerry and others before. Nobody wants to go back to shelter in place. And so how do we start to live our lives? And I'm going to just start with saying that we have to take a tempered approach. And as somebody who's responsible for working with the chancellor in terms of opening UCI in the coming weeks, a tempered approach is where we need to be. The first thing I can say is that the more vaccinated people, the better. On our campus, we are upwards of 90% vaccinated for our faculty and staff. And our mandate, as you know, is to get up there for our students as well. Next slide, please. So Delta variant, here's what we're up against. We have this variant, and variants occur when we don't have enough of the population vaccinated. Here's the problem. We have about 50% of adult populations not getting vaccinated. We have a waning immunity, which is contributing a little, although not that much, but we can talk about that more. And then we have an entire population of children in Orange County. That's almost a third of the population who are not yet vaccinated because the Food and Drug Administration has not come out with at least an EUA, which I think they will in the next month, if not sooner, that get children vaccinated. Until we get our children vaccinated, we are going to be dealing with COVID. And until we get most of the adults vaccinated, we're going to be dealing with variants. And so we have this highly transmissible variant. It is much more than 2 times as contagious. And so remember, in the early days when we were sheltering in place, the transmissibility level, or what we call the R0, the reproductive rate, was about 2. And so for every person, so if I had COVID and I came into a room of unvaccinated people, I would likely infect 2 people. Now, if I was in the same scenario with Delta, I am likely to infect 6 to 8 plus people. So it's not the virulence, how nasty the virus is to your system, making you sicker. It's the transmissibility. This is a total numbers game. I'm going to talk about that, but let's finish. The Delta variant now accounts for almost 100%, 98.8% of all COVID cases in the US and in California. There are some vaccinated people. We've all heard stories. They are true. They are not anecdotal. There is breakthrough. And there's breakthrough because at any one time, we're dealing with 50% of a population not vaccinated. And it's really just a matter of if there's access, if there's access to individuals who either have a weakened immune system, a waning vaccine, or immunocompromised, or are not vaccinated. Those are the folks more likely to have breakthrough. The good news is that almost 100% of all breakthrough in vaccinated folks is mild to moderate, like the worst, like a nasty flu. The vast majority of people who are vaccinated are not being hospitalized and they're not dying. The numbers of people hospitalized and dying are the unvaccinated. Of course, we know that the very, very small percentage, there's also people who are significantly immunosuppressed. We also know, unfortunately, that fully vaccinated people with a breakthrough can spread the virus. What we know now is that the viral load is a little bit lower than in unvaccinated, and the time in which you are able to spread it is much shorter, but there still is a risk, which is why we are still quarantining and still isolating vaccinated people who are symptomatic. But again, the greatest risk is among unvaccinated. And so we are back in this layered prevention where we need to reduce transmission with masks, et cetera. And there's talk of, and certainly for those that have any kind of immunocompromised issues, cancer, other autoimmune disorders, the recommendation is that you get a booster. And I'll talk a little bit in discussion about a third vaccine, just to say that it's the same thing in theory. You're getting a vaccine 3 times, whether it's a booster or whether they call it a third vaccine. But the reason people would say a third vaccine is if they've done antibody titers on you, and some people don't have the same antibody response. And so you need a third vaccine to get that response up. A booster is, the thinking is you have a good antibody response, but the antibodies are waning, which is what there was a study I just saw of 11,000 healthcare workers out of San Diego, and the efficacy, go next slide, please. The efficacy, how protective the vaccine is, was remember, it was about 90% for COVID #1, and especially 90% in the original COVID, 90% in keeping you out of the hospital and in from death. The numbers are similar against Delta for the hospitalization and death, but the efficacy of making you sick or not has gone from 91% in the original COVID for the vaccine, Moderna, Pfizer, down. People are talking to about 61 to 72%, right? So you are more likely to have breakthrough and more likely to get sick with Delta. Because it is more highly transmissible. We talked about the waning immunity on top of that could reduce the efficacy of the vaccine to as low as 50%, especially in people who are immunosuppressed. We're not likely to get herd immunity. Remember, we talked about herd immunity at 70 to 75%. Well, now we're talking about herd immunity needing to be up to 90 to 95%. And don't get frustrated. It's just the nature of science. We need to see what happens, unfortunately, in large populations to really get a good sense of what these numbers look like. You know, most virologists out there always said herd immunity would be at 90 to 95%. And remember, that's of an entire population. So we're talking about children who we can't even put into the equation because they have not yet gotten vaccinated. So we can't even begin to think about herd immunity until at least 90% of adults are vaccinated. So I'm giving you the hardcore facts, I think, where we think we are. Next slide, I'm almost done. So how do we live through Delta? And we can live through Delta. You can live through Delta if you are vaccinated. You can live through and not have a breakthrough by being measured, by taking a tempered approach to the way in which you're living. So it means always thinking about what positivity rates are in the communities that we're living in or traveling in. So unfortunately, Orange County is really at high. It's really at a high level of risk right now. 137 per 100,000. And you know, you don't have to know the numbers. You just have to kind of know what the risk level is. And we are at high risk. It means we take protection. It means that when we are indoors, outside of our intimate family settings or outside of being in a room by oneself, we should be masking. If we are in large crowds of people, we should be masking. I'm already accepting the fact that you're all vaccinated. And if there's anybody here that's not vaccinated, and because they are concerned about the vaccine, call me, talk to me, because not here in a whole group, but really I want to try to convince you. I heard this great story. A friend of mine said he was speaking to a gentleman who was, close to 90. And he said, well, of course you've been vaccinated. And the gentleman said, well, I haven't been vaccinated because I'm concerned about long-term effects. And we all laugh at that, right? Because, we want those that are 90. I want to be 110 before, I meet the maker. But I have to say that we shouldn't be worried at 90 about long-term effects. We should be worried about getting through COVID until everybody's vaccinated and then living a long life. So again, really trying to understand, and that's what all the travel advisories are. I just said, I just got back from traveling to Europe. I actually made it in that short period of time when they were letting US travelers who were vaccinated in, and it was all very civilized. We couldn't go anywhere in any place without our vaccine card and some contact tracing, and everybody put masks on in large crowds and inside. We are in a transitional period. The New York Times said today, maybe we're at the peak and we're going to go down, and talked about all different explanations for that. We will peak and we will go down, and it will probably be in the next couple of weeks. But I just heard the other day of another variant. Until we get the large proportion of people vaccinated, we are still at risk for variants. Take a measured approach to seeing friends and relatives, really, see if, and here in California, we have the added luxury of being able to do almost everything outside and distance. Still do it. It's definitely worth it. It's not that your friend is taking less risky behavior, but who knows? They were in the grocery store and somebody coughed on them, and maybe they weren't wearing their mask right, and maybe they didn't have a great uptake in immunity, and you just never know. And so a measured approach, always choose outdoor versus indoor. I now look for restaurants that are outdoor, and I still go and enjoy a nice meal, as I'm sure you do. And then the last thing is, choose flu vaccines, because it's going to be awfully tricky to, and for you and for everyone else, to try to figure out if you have the flu or if you have Delta. Next slide, please. And then the goals. So we talked a little bit about reaching herd immunity. It's going to be hard until we get the kids vaccinated. I've been very vocal, and I think everyone in public health continues to be. The Food and Drug Administration has got to get this study and really got to evaluate it. We've got to get those kids vaccinated. We have vaccine hesitancy versus resistance versus access. There are still people in communities that don't have access for whatever reason. And so that still exists. That's probably about 10 to 12% of the population not vaccinated. I've met with different essential workers who are in food and other kinds of essential industries where they're working in small places. They haven't gotten around to getting vaccinated. And so we're really trying to move those people to have access. There's hesitancy. And then there's actually, science denialism, and we just have to get those numbers really down. Use yourself as a model of success to anyone who's hesitant that's talking to you. Equitable distribution of resources is really about access. Global vaccine resources. There's a lot of discussion about not getting a booster because the rest of the world hasn't gotten a lot of the world still hasn't gotten vaccinated. These are discussions that keep going on. We were talking, the information is so tough. It is so hard. The truth is, the basic tenets of this disease have not changed since the beginning. But there's just been misinformation and the use of misinformation. When I was doing work in polio a while ago in 2013-14, when they were killing workers who were going door to door in Afghanistan and Pakistan, who were trying to give children polio, the most common reasons for refusal were that their children were going to be sterilized, or there was going to be reproductive problems. Does that sound familiar? So misinformation is the same the whole time. There's no reason to think there's any reproductive issues now. There wasn't any with polio vaccine, but it scares people enough to make them hesitant. And even if they themselves get the vaccine, a lot of parents don't want their 12-year-olds to get the vaccine or 13-year-olds to get the vaccine. And so that clear misinformation, bad messaging is getting out there. And we have to get the right messaging out there. And we still are going to need to be in this place where we're going to need to check on the positivity in the community we're living in. When it's low, we'll have a little more freedom. When it's higher, we need to be wearing masks and social distancing and taking precautions. And again, we are in a rapidly evolving science. Many of you, my first epidemic was HIV, which was HTLV3 when I started. And if you remember, it was rapidly evolving science. They were evicting people from homes because they were HIV positive. This is not the first time we've been in this rapidly evolving state. We just have to be comfortable with it and go to the right sources for our information. Next slide, please. So, recovery and resiliency. This is something that has changed all of us. whether you are 5, my 5-year-old granddaughter, will talk about mask wearing. She told me she started kindergarten and a boy next to her was not wearing his mask. And she said, will you please wear that mask for all of our safety? And so it is a time where all of us have struggled. We've been anxious, we've been depressed. The new normal is a different normal. And we are going to have missed a year to 2 years by the time we really get out of this. So allow yourself time to grieve, time to heal, come together, whether it's virtually or outside, and just know that everybody is valued in our community and everybody has gone through really tough times. And if you really, there are going to be people that we see and know, or maybe ourselves, who really can't, this was too much. And so those people need extra resources, and that's okay. We just have to make sure that we get them those resources. Next slide. And so I just, I'm just putting it in here. We're all about promoting equity. We're all about working with community. I'm not going to go through this slide again, but that's who we are. That's who public health is. COVID has been primarily a public health problem, not a healthcare problem. Next slide, please. And then this was just equity is not a simple solution, but rather that everything we do needs to take on a health equity lens. That is probably the worst part of this entire epidemic, was that we had such disparities by age, disparities by race, ethnicity. Next slide. And so, I'm going to end with we are public health. And we're here for you. And please let us know if there's anything you can do for us. And the last slide, we'd love to work with you in any way. We're doing a lot with supporting the next generation of public health leaders, building community partnerships, getting information out there. And so if you want to join us in any way, please let us know. So let me open it up for questions. Thank you so much.
Thank you so much. That was wonderful information. And I do have a few questions. The first question is the timing of the third shot or booster, because some people who are not immunocompromised are saying, well, should I just go get it now? President Biden is saying 5 months or 6 months, and the CDC is saying 8 months. And people are very confused about how do you know when your immunity is waning?
Yeah, that's a great question. So sadly, the committee that was supposed to vote on boosters decided this last week, decided not to vote. And so there is, despite what President Biden said, there is, except for those that are immunocompromised, there is no policy yet about boosters. I suspect that a policy will come out. People say that they need a little bit more data. They're looking at the data now, because remember, we only got vaccinated. The earliest really for lay folks was January. All right. So we are only at 8 months now. And that's only some people that got vaccinated. A lot of those people were high risk. So they're already in that you need to get a booster. But for others that don't meet the high risk, there is no policy yet, although I think we'll get something in the next few weeks. And I think what it will be is probably something around 7 to 8 months. But again, I think they're still looking at the data. We've always talked about boosters. I think the hope was that we would not have to get a booster for at least a year to 18 months. The data that we're seeing right now, real time, looks like that immunity is waning a little bit earlier than we had thought. If you meet the immunocompromised category, and I'm going to say it in its most broad way, get a booster. Because that's what the EUA approval is for. If you don't need it, I would say hang tight, because I think that there will be some policy out there in the next few weeks. But that isn't to say if you go to CVS Pharmacy today and had your vaccines in whatever, January, February, and you hand them the vaccine card and say, I need a booster, I'm at attesting that I'm immunocompromised, they'll give you that booster. I hope that answers the question. Is there a way to test for antibodies? So that's a little bit more challenging. There's two trains of thought on antibodies. There's the group that says, oh, like the antibodies we use when we were looking at antibody prevalence in all of Orange County, we used an array of 10 different kinds of antibodies. If you go to just get an antibody test, if your doctor orders one, there's only really 2 antibodies there. And so there has to be some better consensus before everybody gets tested. If you are thought to be immunocompromised and your doctor wants to see if your first COVID booster took, if you developed antibodies there, he's using a wider array of antibodies. There's no great consensus about which are the best antibodies to look at. There's at least 10 of them. There could be more. So that, I know that doesn't sound like a helpful answer, but that's really the truth of where we are with antibodies.
Thank you. I'm going to go through some of these questions from the beginning, if I can get my mouse to work. Just want to let you know, if anybody needs a review of this information, it will be going on demand at the JCC on our website within a couple of days. The next question is about antibody response. Are there specific COVID antibodies? I think you already went into that. There's many of them. Do you want to say anything else about that?
No, there's many of them. Some of them are in academic settings, like UCI has a very big virology, immunology vaccine group, but what's available commercially, what your doctor's going to order, are really limited numbers of antibodies, and that may not give us the full answer.
Okay. Somebody, just for information, said a useful resource was smartpolitics.org, how to talk with the unvaccinated. And that's a very good point, because lots of times it does get into a conflictual situation.
I know, it's very tough. I feel like public health is really at this place right now. Its future depends upon defense of science and explaining the scientific process and what makes scientists comfortable with the vaccine. My mantra, as my UCI comrades will know, is that I'd like one person in defense of science at every Thanksgiving table in America this year. Maybe that would get some vaccines, get the vaccines up. Really, we need to be able to defend science and then understand the place where people are coming from. And then I think we can have that conversation. So you have a great resource. Thank you for sharing.
Thank you. This question is about the third vaccine. Is there any data showing if strong reactions to vaccine 1 or 2 are predictive of a very strong reaction to number 3?
No. So what I've read is that your vaccine number 3 is actually usually less of a strong reaction or experience. I ended up getting this very interesting square bump that on my arm after vaccine 1, which was not uncommon at the vaccine site. I put, just a heating pad on it. Vaccine 2, I had absolutely nothing, but just felt like achy, just felt like I want to go to bed early. And I have not heard for vaccine 3 that people are getting even those reactions.
Okay, thank you. The next one is about I'm planning a trip to Vancouver and staying in a hotel. Should I be hesitant? Should I be concerned?
So right now, Canada's numbers are looking pretty good. And they're still allowing us in. So maybe it's a good opportunity. Check the numbers where you're going. That's the key. In the airport, you want to get there and you want to sit distance. You want to keep your mask on, always sanitize on the plane. That's what and your mask is going to be on the plane the whole time. No, I think that most of these hotels have been really great about needing to show a vaccine card. Oftentimes they're only cleaning the room every couple of days. And a lot of trips, even the Alaskan cruises now, are vaccine only, which really significantly lowers risk.
Thank you. Here's an interesting one. What types of programs are offered at UCI if you want a future in public health?
Oh, well, we have all different programs. So the Master's in Public Health is sort of the workforce of public health. It's a 2-year degree, and it is the professional degree in public health. And we do epidemiology, infectious disease epidemiology. We do global health. We do health promotion, which is really about educating communities, working with communities to try to understand and improve health. And we do environmental health sciences. Again, we have a huge center for environmental and occupational health. We're working on climate change and health. We're working on, again, clean air and clean water. So those are the master's level programs. We have 1,200 undergraduates, and they are learning to do public health policy and public health science. So they will come out, and whether they go into public health or law or medicine, it's an exciting degree. And we're probably one of the largest, most diverse, and one of the best undergraduate public health programs in the country. And then we offer a doctorate in public health, a PhD in public health, which is a 5-year program that spans all of the kinds of public health disciplines.
Wow, thank you.
And call us any age, anytime. We've got a lot of exciting things going on. And I would just say, and if you're in an organization that might want to use public health students, call us, because our students have to do because of accreditation, 200 plus hours of real practice-based experience.
That's really good to know. Thank you. The next question is, what's the probability of a vaccinated person contracting COVID?
Okay. Well, so what's the probability of a vaccinated person? I think we talked about all the different things. So remember that for Delta, there's a decent probability probably of contracting Delta in a high risk situation is probably a couple of percent. 2%, 3%, it's real. In a low positivity situation where there's not a lot of Delta and there's not a lot of COVID, it's probably 0.
Okay, thank you. Another question was, the doctor told me to stop aspirin before the shot. How long before the shot are you supposed to stop that?
Okay, so some people are taking things like aspirin or other things that could interfere with the uptake. It really depends upon what your doctor says. It's probably anywhere from 12 to 48 hours, depending upon the dose and the reason. So that is something you want to ask your clinician specifically for you.
Okay, thank you. The other question was, what is the difference between the vaccine and the booster? I think you kind of talked about it.
Right. It's the same. Right now, it's the same thing. I think what we had originally imagined was that these boosters would be more sensitive to the variants like Delta, et cetera. But right now, it's more about just keeping that immune response up. Again, the most important thing about these vaccines, and if you think about flu, it's the same. It's not only, it would be nice not to, it would be nice to prevent COVID overall, but we really just want to prevent bad COVID, long COVID, or COVID death. And that's what these vaccines really do a good job of. In Delta, again, we're seeing some breakthrough in mild and moderate illness.
Okay. Do you have the positivity data for each OC community?
That's, I would say that you know, Orange County Healthcare Agency probably does, or you could probably calculate it, but the community is small enough that it's just worth looking at the overall positivity rates for the whole community. Because even if you don't go out of your small community like Irvine, other people are coming in and out of Irvine. So I think it's reasonable thinking about how people move around to use county level data as to give you a sense of where what's going on with COVID and what the risk level is.
And the next question is about Uber. Or
Yeah.
someone doesn't have their self on mute. Can you you see your picture there? Could you mute yourself? Because the noise brought your picture on. Otherwise, let me ask the next question. Is it dangerous to use an Uber or Lyft?
If I'm going to use an Uber or a Lyft, I would just make sure I have a mask on. That's all. And you should ask the Uber Lyft driver to have one on as well. If they won't wear a mask, then call somebody else.
Okay, I'm looking to mute someone, but all right, let me move on. Oh, I see who it is. Delta Airlines is requiring vaccine. That's all that's in here.
Yeah. So in my flight to Europe, I had to. I think in international flights, a lot of carriers are now requiring proof of vaccine or proof of COVID proof of a negative COVID test less than 72 hours. And basically, by the way, in all of Europe and the UK, people are just getting tested and showing this. This has become much more routine than it is here. I flew to Hawaii in May, and there was a requirement for both and there isn't anymore. I think it's changed or it's rechanged again. So just keep checking with your carriers if you're going.
Thank you. Another question is comparing booster efficacy if you take a booster that is different than your original vaccines. Is it?
Yeah, I mean, you know, we talked about this. This is it's interesting. This is probably more a matter of what should have happened is that we should have done a huge study which said if I get Pfizer for the first and I get Moderna for the second, they're the same kind of vaccines, messenger RNA. If I get Pfizer for the first and Moderna for the second, is my efficacy okay? Or if I get Moderna and I get Pfizer, is that okay? The truth is, intellectually, scientifically, there's no reason to believe that there would be any differences. And the EUA states that whether you got Moderna or Pfizer, if you qualify for a booster, you can get what is out there now, Pfizer. Moderna will come out very soon with a booster as well, but there is no reason to think that there would be any differences in efficacy.
Okay.
They're beautifully efficacious. They are really good. For the first COVID, they were great. You know, I mean, we shouldn't be in Delta. We should have gotten everybody vaccinated. So.
And then we have a question on masks.
Yes.
Is it easy to get them? Do you use cloth mask, blue mask? What's the best mask?
Yeah, so obviously the N95s are great masks, right? They're hard to get still, but they're great masks because they have that little thing over your nose, which allows the little sort of semi-metal, which allows it to kind of rest over your nose and keep your face secure. That is the best kind of mask, something that has some kind of allows you for secure, but the double cloth is absolutely fine. I have a UCI public health one that I use. The key thing is to keep it over your nose and mouth unless you're not, because of health issues, able to do so. So people going around like this is not helpful for themselves or in terms of COVID or for other people. You need to cover your face. And so you really just, there's a lot of masks out there that are fine.
Thank you. I think you've answered this. Does the vaccine cover long haul disease? so we can.
So
move
we
on.
think it does, and long haul disease, but the problem is we've never seen long haul disease like this. And so, yes, that is the goal. You're not going to get COVID, or you're going to get it mildly, and you're much less likely to get long haul disease.
And is it safe to attend a large indoor-outdoor wedding that's requiring all attending to submit negative COVID tests?
Well, that's fantastic.
Yeah, yeah.
I'm hoping it's under 100 people or 150. I'm planning a wedding for my daughter, and yes, outside is great. Requiring COVID testing is great. They're doing all of the right things. Distance, maybe not hug everybody that you know. So.
Okay. Okay, there was a question about Moderna. Did you say, I don't think you said this.
Okay, so right, all right. So there's two things. Let me talk about the boosters again.
Okay.
Right now we have FDA approval, right, in the form of either emergency use or full approval for Moderna and Pfizer as vaccines. We have which is two shots, 2 injections. We have Pfizer was approved for a booster, and it's under emergency use approval, and that is what CVS is typically has been offering as the 3rd booster. Moderna's EUA approval for a booster, a 3rd shot, will come out, I'm sure, any day. So right now, if you go to the pharmacy for a booster, you are most likely, according to the regulations of the country, to get Pfizer. So even if you had Moderna for your first 2, you will get Pfizer right now. That's kind of the FDA law. So all I was saying before is you shouldn't worry if your booster is Moderna and you had Moderna for the first for your vaccines, or if it's Pfizer and you had Moderna. It doesn't matter, is what the science community is saying. But what is actually able to happen legally is that right now for a booster, we are only, the CVS pharmacies or the pharmacies are supposed to be just giving out Pfizer. It's just a matter of the regulatory agencies reviewing the data on boosters. Okay, so if somebody's offering it because they have supplies, that's fine. I'm just giving you a what's regulated right now.
Okay. This I hope is I think. Oh no, we have more questions coming in.
Will there be a J&J booster? I just saw that.
Yeah.
J&J is more complicated. J&J is more complicated. I think they're talking about a booster. Let's see what the Food and Drug Administration says. So J&J is a little bit different kind of vaccine, and so they're going to need to have the Food and Drug Administration regulatory oversight on that.
Okay. A question I missed was, is the scientific community divided on the need or benefit for a booster?
It is absolutely divided. It's very, very interesting. So yes, it is. And I think that's why there was nothing voted on, between not having enough data, which would mean thousands and thousands of tens of thousands of people's sort of titer or antibody profiles over 8 months. That's what the kind of evidence for that science is going to accept as really critical for a booster. And what Pfizer, I believe, has shown is that there is waning, waning antibodies, and more importantly, that the 3rd vaccine boosts that antibody, those antibodies. So here's the problem: we don't really know what the level of antibody, what our antibody level should be to be fully protective. We know what works because Pfizer and Moderna showed what works. That's how we get 91% efficacy against the original COVID, but we don't really know how low is good enough. And so that's what we need science to help us a little bit more there.
And there was a question about Israel. Let me just see. Wait, I have to go back. Oh yeah, how much does the FDA and CDC rely on information from Israel?
Oh, the Israelis have done a fantastic job of documenting their experience and really providing a lot of great outcome. So the Food and Drug Administration, when evaluating whether you need a booster, will certainly take the Israeli work in hand. Absolutely.
Okay. Another question, if we choose to get vaccinated 5 months after the second shot, what's the downside? I want protection. Is surely the protection from the first 2 shots wanes gradually over time, and there's not a falling off cliff after 8 months?
Yeah, there's probably no real downside. That's what we've been talking about in the scientific community. But it's really good to have time to let your immune system work. So I would say right now there's no evidence of a downside to that.
Okay. Yes, somebody's just saying the CVS pharmacy on East Bluff is offering booster shots. You can walk in, or no need for an appointment. I think that was it. How about if we open up the screen to everybody, and in case there's somebody who wants to wave their hand or something and unmute themselves with a last, we have about 5 minutes left for questions. So if there is anybody else, you can unmute yourself one at a time. Oh, there's Maura. Go ahead,
Hi.
Maura.
Hi.
Last week I was traveling. I was in Gettysburg for part of the week and then Philly for the other half. And Gettysburg, you wouldn't even know COVID existed.
Yeah.
There were like no masks, even in the federal building that was the visitor center. I mean, the workers, they were wearing masks, and there was a sign saying to wear a mask, but people inside were not wearing it. They were not enforcing it. And that is it's just terrible. I felt like so uncomfortable. Philly, on the other hand, was very masked up.
I have to say, I'm on the phone with all of my fellow deans of public health schools around the country. And, some schools like the UCs, we have a mask mandate inside, vaccine mandate. And then I talk to my friends and the colleagues in Texas, in Florida, and, they're crying because there's nothing that they can do. And people are getting sick and dying. It's terrible. When did public health become political? And I'm really, and again, I think there's a couple of things going on. I think we need to feel more comfortable about the scientific process. Even as we've talked about today, there are things that are always going to be unknown. And it's too bad that we don't. So we need to do public health civics across America in our school kids, because they're the ones at the end of the day that are going to take us and lead us down the right road. And we just got to get away from the politics. This is the health of the community is the most important thing for your individual health and the community's health. Public health has always been has always intruded a little bit on individual rights. And I know individual rights are critically important, but when we have a pandemic of this, this largeness, we really have to take community health. And so into mind, and we should be incentivizing those that do the right thing and mask and vaccinate, which is why I really liked in Europe, where you just couldn't go to a restaurant if you weren't vaccinated, right? Or didn't have a negative COVID test. So it's sad. I think we have to keep getting out the message, and everyone's got to have that message. And it's really got to be in defense of science, because I think that's the big issue. So thank you for sharing that. It's very frustrating. So I would just say, know where you're traveling. So travel to Florida right now is precarious. Those numbers are very, very high. And I know we have loved ones, my mother-in-law and sister-in-law in Florida, but we're not going there now because it's just very high risk.
I see there's one more question. Carolyn, you have your hand
Yeah,
raised.
yeah.
Go for it.
Which is, so if I'm masked and I've obviously been vaccinated and I'm in an indoor situation like the grocery store, and there are lots of people around me that aren't wearing a mask, does my mask protect me?
Yes,
Or-
your mask and your vaccine are protecting you. It would be best if everybody was masked, but they are certainly protecting you. I just distance. That's what I would do. But
Mhm.
yes, yes.
Okay.
Okay.
Thanks.
And I